Thank you. It's an honor for me to speak here to this mixed audience, which is always a challenge for me and others, but we'll do what we can. I'm going to talk about a good news area, and that is improvement in the outcome for a subset of breast cancer known as the HER2 positive subset of breast cancer, which a few years ago as a clinician I would hate to see, because these were patients with very aggressive tumors that often were fatal and required very intensive chemotherapy. Some of them were cured, but many of them were not. And over the past decade, remarkable improvements in outcome have happened. And now, as you'll see, HER2 positive breast cancer has been converted into a good type of breast cancer to have. And I now love to see patients who have this subtype of breast cancer because the improvements in treatment that have come about largely through a greater understanding of the biology of the disease. So first, overall good news with breast cancer as a whole is shown here. And this is a slide that came out a few years ago, 2010. The data continue to hold, but this is mortality rates from breast cancer starting in 1950. You can see they're rising in both the United Kingdom and the United States. And then something happens. They begin to plateau, and then mortality rates start to come down, dramatically come down, starting around 1990. And they continue to fall. And this is due to a variety of factors, most notably better treatment, also a contribution from screening and earlier diagnosis, and also a contribution now from breast cancer prevention, so attacking it from multiple fronts. So the question is why did this happen? And that is shown schematically in this timeline, the key events in breast cancer history. I was a third-year medical student in 1970 at the very far left of this slide. And at that time, all patients with breast cancer were treated identically. Everyone had a radical mastectomy. Patients tended to present with rather large tumors at that time. Everybody, or many of the patients also received radiation to the chest wall afterward. And this was no matter what kind of breast cancer they had. Big, small, what we now know to be a good prognosis cancer, everybody was treated the same. And so it was a surgical disease. We had very little hormonal type therapy to block estrogen. In fact, I remember the biggest argument when I was an intern was how to best take the pituitary gland out, which was a treatment for breast cancer back in those days. And then something began to happen, most notably the war on cancer, which was initiated in the Nixon administration in 1971. It started to pour more money into cancer research in general. And that really started, I think, the revolution in understanding of cancer and better treatment for cancer. And one of the first concepts that came about in the mid-70s was the idea that breast cancer is really a systemic disease. And that is by the time breast and other cancers are diagnosed, the horse is out of the barn and down the road. That is, it has already sent seeds of metastasis, cells that go to other parts of the body via the bloodstream. You can't see them when the patient first comes in. A patient comes in with a lump in the breast. There's no evidence of cancer anywhere else. But if all you do is remove the tumor surgically, many of those patients die. In fact, back in those days, half of the patients died, even though you couldn't detect by any test or anything on exam metastatic breast cancer. So the idea came about that those seeds are already there. They weren't dislodged at the time of surgery, and that we have to rethink how we treat breast cancer. First of all, maybe it doesn't do any good to remove the radical mastectomy and remove all the chest muscles and everything if your survival is determined by having little micrometastases in your liver, bone, or other places. And secondly, that means you need to give a treatment that gets into the bloodstream that eradicates those seeds. Okay? So that was the concept that breast cancer was a systemic disease. It seems so obvious today because the hypothesis has clearly been shown to be correct. Back in those days, it was heretical. In fact, one of the surgeons that proposed this idea, Bernie Fisher, was ostracized from all the surgical societies at that time. And now, of course, he's known as a real breast cancer hero. So that led to the idea of lesser surgery, so lumpectomy, and it led to the idea of giving systemic therapy into the bloodstream, whether that be therapies that block estrogen, which is a major contributor to breast cancer, or chemotherapy or other factors that I'll tell you about in a minute. And those two ideas, lesser surgery, more systemic therapy, is what has led to the decline in mortality from breast cancer over the subsequent decades. Also, screening came into play when 3 famous women got breast cancer, and they had small breast cancers detected by mammography: Betty Ford, Happy Rockefeller, and then Nancy Reagan. And then research over the next decade began to introduce these concepts into the clinic. And then in 1990, or just before 1990, another gene that contributed toward breast cancer was identified called HER2. And it was found that about 20% of breast cancers have gene amplification for this gene, and that was probably what was causing and driving the tumor to grow. And investigators set out to devise therapies that would block this protein on the membrane of cells. And that's what I'm going to focus my talk on today. But later in the 90s, other forms of blocking estrogen came about that were very effective. Prevention studies became available. Now there's 6 or 7 prevention studies that show if you block estrogen, you can reduce the risk of breast cancer in high-risk women by 50 to 60 to 70%. The idea that we can identify those few patients, about 5 to 10% of patients who have a hereditary gene mutation, came about, and we now do that routinely, and we can target those women for prevention or close monitoring. And then about that time was when mortality started to decline. And then most recently, we've entered the era of precision medicine, where we can identify specific subtypes of breast cancer based on their genomic profile and target treatment specifically for individual patients, so-called targeted therapy. And that's what I'm going to talk about today with regard to HER2-positive breast cancer. So precision cancer medicine is simple. It's measuring a characteristic, usually a genomic characteristic or a proteomic characteristic, in an individual patient and their cancer, both, to determine the genetic signature in the tumor, that, or fingerprint, some people call it. That tells us many things about the cancer that we now know about today. The aggressiveness of the cancer, and it tells us something about what the optimal treatment might be for that patient. So with that in mind, still although there's many, many genomic and genetic subtypes of breast cancer, there's 3 types therapeutically that we think about basically in the clinic. The most common is the type that expresses the estrogen receptor protein. Those are driven by the hormone estrogen, and therefore treatments that block estrogen are the best therapy for these. Okay. The second type is HER2. And the third type doesn't have any of these receptors in the tumor, and it's called triple negative. And that is a major focus of everybody's research now, to try and find out what it is, what's driving those tumors to grow, to develop and grow, so that we can think of new treatments besides chemotherapy, which is the only treatment we have for that subtype of breast cancer today. So estrogen receptor is responsible for the growth of these tumors and the survival of cells. And for HER2, there's multiple copies of HER2. It's gene amplified on the cell surface, and it's a growth factor receptor that causes these cells to grow rapidly and metastasize widely and early on. For triple negative, as I mentioned, we don't know what that factors are. And the targeted therapies for the ER-positive tumors, we now measure that routinely in the clinic. We've done that ever since the late 70s. Those tumors that are estrogen receptor positive will invariably be treated with a therapy that blocks estrogen in some way, and that's very effective therapy. For HER2-positive breast cancer, what I'm going to talk about next, they're treated with anti-HER2 therapy, sometimes also with chemotherapy, but therapy that blocks the HER2 oncogene. And that has made a huge difference in the outcome of these patients. Let me move on to the next slide. Okay, so what is it about this HER2 gene? Well, first of all, it's an oncogene. You put it into animals in their breast tissue and they get breast cancer very rapidly. So it's a very potent oncogene. It's gene amplified in about 20% of breast cancer. When it's there, it causes an aggressive, rapidly growing tumor, and treatment has been aggressive chemotherapy, which luckily is relatively effective in and of itself. One important thing that was overlooked for many years was the fact that the activation of this pathway not only requires HER2, but it requires other members of this growth factor receptor family, as I'll mention in a minute. And then finally, Trastuzumab, which is an antibody that was developed 15 or 20 years ago now, And it's an antibody that binds to the external domain of HER2 and blocks it. Also induces antibody-dependent cellular cytotoxicity and immune reaction. And that has turned out to really turn the corner in these patients. And it's extremely effective and has markedly enhanced the cure rate when given with chemotherapy. So here's the pathway. There's the cell membrane with the 4 receptors in this family, HER1, 2, 3, and 4. And it's a very complex network. I like the word network in Dr. Levine's talk because that's how cells work. They thrive on a series of networks that keeps them growing and keeps them alive and adapts to stress and all kinds of other things that a cancer cell undergoes. And so there's 11 ligands, hormones that circulate in the blood that bind to these receptors. And when they do that, there's a few of them shown on this slide, it induces a conformational change in the receptors and they homo and heterodimerize with each other on the membrane. So that's the input layer into this network. And that sets up a signal that then transfers the signal from the membrane to the nucleus via a series of phosphorylation steps and mainly down 2 big pathways called the PI3 kinase AKT pathway or the RAS-MEK MAP kinase pathway. And that signals to the nucleus for transcription factors. New genes are transcribed, and those genes are involved with proliferation, migration, differentiation, and anti-apoptosis of the cancer cell. It's what drives the cancer. It's important to realize that HER2 does not act alone. And although Trastuzumab, that antibody, its main effect is on HER2, these other hormone receptors are also important, even though they're expressed at very low levels on these cells. But once we understood the biology of how these 4 receptors work together, it gave us clues about how we could make the treatment even better. So here's Trastuzumab. It's the monoclonal antibody. It's given to patients, binds to the external domain of HER2, and then it blocks the signaling coming from HER2 homodimers mainly. But it's a very weak inhibitor of HER1, HER2. It's not an inhibitor at all of HER1 homodimers. And it's a weak inhibitor of HER2, HER3 heterodimers. So it only partly blocks the pathway, and that's an important thing to remember. Nevertheless, despite these tumors having multiple genetic abnormalities, thousands, all these breast cancers have thousands of genomic abnormalities. Despite that, if you block this one gene product, HER2, with an antibody, you have amazing results in the clinic. And that's what's shown here. This was one of the first experiments published several years ago in patients who came into the doctor. They measured a HER2 in their tumor. The HER2 was positive. And they were randomized to a trial of aggressive chemotherapy. That's what AC followed by T is in the blue line there. Adriamycin, Cytoxan followed by Taxol. So about 6 months of aggressive chemotherapy with its side effects. And then the other group got the same chemotherapy with the addition of Herceptin. And you can see the dramatic improvement in outcomes. 67% were disease-free in the chemo alone group, 85% with the addition of Trastuzumab, which has almost no toxicity. In fact, when you're giving it by itself, essentially has no side effects at all. And so the recurrence risk was reduced by half. That is, half of the patients that would have recurred with just chemotherapy alone, that recurrence was avoided by also adding in the Trastuzumab, which they got for 1 year. Now that was really good. It reduced the death rates and the recurrence rates by half, and many of those patients are cured and never have a recurrence of breast cancer again. But still, half of them don't benefit. So the question is, they've got HER2 amplified in their tumor, you're giving them the Trastuzumab, and yet it doesn't work. So why is that? So that's been one of the focuses of my group, is to try and figure out what the mechanism, what the molecular mechanisms are for this resistance to Trastuzumab itself. And can we then, if we know that, can we come up with better therapies in this subset of breast cancer? So HER2 is a good representative of what has been named the oncogene addiction hypothesis. And that states that there's a cell that is driven by a single powerful driver pathway, like HER2, but there are other redundant survival pathways in a cell. Our cells, normal cells, have multiple pathways to keep them alive under various stresses. But when you have HER2 amplification and a really potent driver, those other pathways are sort of downregulated. They become less active because they're not needed. But they can be reactivated if called upon when HER2, the main driver, is blocked treatment-wise. But nevertheless, If you block that main driver, in this case HER2, and you do it quickly and completely, you can kill the cell. And that was the whole basis for the improvement that I showed you on the previous slide. Really one of the clear demonstrations that the oncogene addiction hypothesis can be correct. But that raises questions. Why don't all the patients with HER2 positive tumors benefit from trastuzumab? Do all patients with HER2 positive tumors need that aggressive chemotherapy that I talked about? Or if they're really driven by HER2, if we just block HER2 completely, maybe that's all they need? And can we then de-escalate treatment in some patients? Or can we add a different therapy that will overcome a mechanism of resistance? So one such trial was just reported. And this trial took patients that had HER2 positive breast cancer, and some of these patients were also positive for the estrogen receptor. These were small tumors, relatively. Many of them were only 1 centimeter in size, so you have to understand that. They were all lymph node negative, that is, the cancer in the breast hadn't spread to the lymph nodes under the arm. And they were all in real good shape. And there was 400 patients registered on this trial, and they only treated them with one chemotherapy drug called Taxol, that's the T in the blue, along with, I'm sorry, that's the orange, the paclitaxel in the orange, along with this antibody, trastuzumab. And they treated him for 12 weeks with both therapies, and then they continued for the rest of a year just with the trastuzumab by itself. And what happened? 98% of the patients were still alive and disease-free 3 to 5 years later. Okay. So that does suggest that there's a group of patients that don't need this really aggressive chemotherapy as long as you target the HER2. Still, there's many patients with larger tumors that don't have this benefit, and the question is why. And if we improve the therapy to target HER2, maybe they don't need any chemotherapy at all. Maybe we can just treat some of them with targeted therapy. So that was where our group came in, the de-escalation without any chemotherapy at all. Can we eliminate cytotoxic chemotherapy in these patients? In some of them, by using more complete HER2 driver blockade. So how do we do that? Okay, so here's the schema again, showing the 4 receptors, trastuzumab blocking HER2. Well, about a decade ago, drug companies began to develop other drugs that targeted other members of this family, because those other members are important for lung cancer and some other cancers as well. And we hypothesized that one of the main mechanisms of resistance to trastuzumab was incomplete blockade of the receptors. So we were leaving HER1 open to stimulate the pathway and cause growth of the cancer. We were leaving HER3 open, and we were leaving HER1, HER2 heterodimers open, and so forth. And we hypothesized that if we could more completely block those receptors, we would improve the outcome of the patient. So how do we do that? Well, there's a whole bunch of other drugs there shown in red that came along about a decade ago, some of them even more recently, that can do this. So if you see there lapatinib, afatinib, and neratinib, those are small molecule kinase inhibitors. They get inside the cell, and they block both HER1 and HER2. So that should add right there, you're blocking HER1. There's another drug called pertuzumab, shown there, and it's an antibody that binds to the HER2 in a different domain than Herceptin does, or trastuzumab, and it prevents the heterodimerization. So it'll prevent HER3 from activating HER2 because it prevents them from interacting with each other. It blocks the heterodimerization domain. And then there's even a newer drug called TDM1, which they went through this thought process. They would add and link a chemotherapy drug chemically to the trastuzumab. Trastuzumab would take that chemotherapy drug that normally is very toxic directly to the cancer cell, internalize it, and bring the chemotherapy into the cell where it would then kill it with very low doses. This drug is not leached off the receptor into the circulation. And that's turned out to be a remarkable new therapy as well with minimal toxicity. So we began to explore using these drugs in combination. And then finally, another thing people overlooked was, what about that group of tumors that has both estrogen receptor and HER2? And because they were HER2 positive, everybody was focusing on that. People thought that estrogen receptor was irrelevant, and it wasn't contributing to the growth. But what we showed was, in our lab, in several publications 5 and 10 years ago, was that in those tumors that have ER and HER2, if you block HER2, what happens? estrogen receptor takes over and estrogen starts to stimulate the tumor. So what you got to do, you got to block the estrogen receptor at the same time. It seems so obvious now, but nobody has done it even until today, okay, in those tumors, except us. So we developed the hypothesis that drug combinations designed to inhibit all HER homodimers and heterodimers would be more effective than a single drug like Trastuzumab by more completely blocking the pathway. Pretty simple. So we began to explore this first in preclinical models, and this is a Xenograft. That's a human tumor growing in a nude mouse that overexpresses HER2 and estrogen receptor, and we began to look at single agents and combinations to see what would happen. And this slide shows these tumors in the mouse treated with tamoxifen. Tamoxifen doesn't work at all. Tamoxifen is a drug that blocks estrogen. Doesn't work at all, even though the estrogen receptor is there, until you block the HER2, as I'll show you in a minute. So then we looked at combinations of tamoxifen plus four other different drugs that block various aspects of the HER2 pathway. There's Pertuzumab in P, Gefitinib in green, the Trastuzumab in purple, I guess it is, and Lapatinib, which is in blue. And each one of those drugs by itself has a pretty good effect. But after a couple of months, the tumors all, in every case, began to regrow. There was no cure of any tumor using single agents like this in this mouse. Then we started to combine them. And here's with one drug, just like I showed on the last slide. Here's two drugs. This is combining Trastuzumab with Pertuzumab. Much greater effect, but still most tumors come back because you're not blocking that HER1 with this combination. You add in a drug that blocks HER1, all the tumors go away, they melt, and they're gone. If you stop therapy, the tumor never comes back. We've never seen that in any HER2-positive tumor with any treatment whatsoever, chemotherapy or whatever. So we got very excited about that. But look what happens if you don't block estrogen. If you give estrogen back to these tumors, even with the potent cocktail, estrogen receptor takes over and starts driving the tumor. So you gotta block the estrogen receptor, even though at the beginning, blocking the estrogen receptor didn't do a thing. They were resistant. Once you block the HER2 pathway, then the estrogen receptor starts signaling and tumors become important. So there's another model that has the same thing. We weren't able to convince the drug company, this is back in 2001, to give us those 3 drugs to try in a clinical trial, even though that company made all 3 drugs. I couldn't believe it. These drugs are $100,000 per year. The company would have made a lot of money, but that wasn't in their plans. So we went to 2 other drugs, Trastuzumab and Lapatinib. Lapatinib is one of these kinase inhibitors that blocks HER1 and HER2 in combination with Trastuzumab. And we found, as you can see in the pink line above and in the black line or blue line below, that it's almost as effective as the other combination. So we and others took that into the clinic, and this is the first study, the Neo-ALTTO clinical trial, that used a chemotherapy drug, this paclitaxel that was used, I mentioned before, so one drug, plus either Trastuzumab or Lapatinib, or the combination of the 2 that had been so good in our preclinical model. And here's their data, shown in red, the complete response rate. These are patients who, before surgery, were given treatment. And then at surgery, they were able to assess, is the tumor still there, or how much has it shrunk, or how much is it gone away completely? And a PCR means that it's gone away completely. And you can see, using the combination, twice as many patients had eradication of the tumor than with one of the single agents. So that seemed to confirm what we found in the preclinical models. We then set aside to do an experiment ourselves that didn't include any chemotherapy at all. It included 12 weeks of Lapatinib and Trastuzumab. Remember now, this was once thought to be a very aggressive cancer. What can we do just by blocking HER2, the receptors a little bit more completely? And that's shown here. It's not as good as when you do chemotherapy, for sure, so many patients still need chemotherapy or they need other therapies. But still, we had a sizable number of complete eradication with just 12 weeks of simple treatment with almost no toxicity, with about 1/3 of the patients eradicating the tumor totally, 21% in ER positive, 36% in the ER negative. We then went on to look at 24 weeks rather than 12. Turned out that 24 was better in some patients. We tripled the complete response rate in the ER positive group and validated that this was an effective approach. Still, even though we're now using multiple cocktail to block HER2, why doesn't everybody respond? Well, it turns out there's many, many different reasons why a cell could overcome this blockade and be resistant to the therapy. And there must be mechanisms other than incomplete blockade of the receptors. So that's what we're working on now, and in fact there are. And you see that P10 right there that just got an X on it, and it's going away. P10 is a tumor suppressor gene that puts the brakes on this pathway. Well, it turns out some breast cancers, some patients in their breast cancer has downregulated that P10. So there, the pathway is activated distal to the receptor layer. So you can throw all the receptor blockers you want on there, and it's probably not going to work if P10 is low in those tumors. The other way, PI3 kinase in the signal transduction pathway there. Turns out about 30% of these tumors have activating mutations in PI3 kinase. PIK3CA is the gene. So we then said, well, maybe those tumors aren't responding to the dual receptor targeted therapy. And here's what we found, and we were right. So in those patients who had a high P10, there was a 30% complete remission rate. Those tumors had a low P10, it was only 9%. And if they had a PI3 kinase mutation, not a single patient had complete eradication of the tumor. So that would suggest then that for that subset of tumors, you don't want to just give them therapies that block the receptor layer. You're going to have to give them, in addition to that, treatments that block PI3 kinase, AKT, or treatments that affect the pathway distal to the receptor layer. So in conclusion, HER2 and its family members are potent drivers of about 20% of breast cancers. Blocking the driver is very effective in a significant fraction of patients, and we've converted, as I mentioned, a bad prognosis cancer into a good one where most patients today are cured. More complete blockade of the HER family is optimal, but it doesn't work in everybody. Some women may need minimal treatment, just these 2 drugs for 12 weeks, and that's it. And obviously that's going to require more study. This is just the first observation suggesting that that might be true. Resistance mechanisms are becoming better understood as we delve deeper into the patient's tumor and the genomics of the tumor. Measuring other factors in a patient's tumor, I think, will provide the cause of the resistance and the drugs to overcome it. So we take tumor tissues samples from these patients, and we're exploring other mechanisms. And finally, this is, I think, a paradigm that has been shown now to extend to other cancers. That is, if you discover the driver in any cancer, a potent driver, or drivers in some cases, it should yield similar benefits in those patients as well. So thank you. These are colleagues in my laboratory that have helped do all this work over the past decade. Thank you.
Ken, the germline mutations in BRCA1 and BRCA2 are limited in the Ashkenazi Jewish population. There are 3, I think, that reach about 90% of the risk factors. And in Israel, there's a screening program which has been initiated at a government level to screen males and basically fathers. So the identification of the risk situation in the male, of course, is not that high. It exists. But now we're going to have the 1 in 2 chance of all female offspring of those individuals who will be at risk and will probably be identified reasonably early in life. So here's an opportunity to intervene on the disease. And there have been 1 or 2 reports that have come out saying that estrogen blockers can reduce the, not incidence, spread out the time interval for the appearance of the neoplasias. Yeah. I wonder if you could comment. Sure. So there's an opportunity to identify the people at risk and to do preventative blockade.
So these mutations are the most common causes of hereditary breast cancer, where you see a family that's riddled with breast and ovarian cancer, BRCA1 and BRCA2. They're not limited to the Ashkenazi Jewish population. They're just more common there. 1 in 80 people in the Ashkenazi Jewish population has a mutation in the gene. In Caucasians in this country, Europeans, non-Jewish people, it's about 1 in 600 or 800, something like that. So we still see it, but it's more common in the Ashkenazi Jewish where there are founder mutations. We don't know a lot about what you just asked. That is, in the BRCA1 group, these tumors that develop tend to be estrogen receptor negative. They're not dependent on estrogen, whereas BRCA2, they are. But what is known is that if you take the ovaries out of these women, which is also done to prevent ovarian cancer, which is also common in the same group, that you do reduce the risk of breast cancer. Of course, taking the ovaries out of a 30-year-old has its problems as well. There's much less information on using the drug tamoxifen. There's a handful of patients that were entered onto the prevention trials using tamoxifen and other anti-estrogen type drugs. And it's not clear whether waiting until you're older, which is all the trials of tamoxifen prevention required you to be 35 or above, and most people were over 50. Waiting until that time may be too late, because these patients get breast cancer very early in life. Many of them in their 20s. The earliest patient I ever saw was 19. I think for prevention right now, most people are talking either about close monitoring with MRI scanning to detect the cancer early, but many of these women have seen their relatives die of breast cancer or ovarian cancer, and they want to have surgical resection. So they vote for prophylactic bilateral mastectomy and prophylactic ovarectomy. Ovarectomy can wait till your late 30s after you've had your family, but breast can occur earlier, and so many of these women choose to have bilateral mastectomies.